I'm going to talk about CAR T-cell therapy, updates on CAR T-cell therapy for multiple myeloma, lymphoma, a little bit about predictors of CRS and neurotoxicity after CAR T-cell therapy for large B-cell lymphoma. If we get there, treatment with CAR T for patients with secondary CNS lymphoma, and maybe one abstract about CAR T-cell for T-cell ALL or /lymphoblast lymphoma. So briefly, I put a few papers as background for a few abstracts that we're going to discuss. This is the first paper recently published in New England Journal of Medicine, randomized trial, ID-cell or standard regimen in relapsed and refractory multiple myeloma. This is a phase 3 open-label multi-center study. Patients had to have failed 2 to 4 lines of prior therapy. Randomization was 2 to 1. 66% had triple refractory disease. 95% were DARA refractory. This is important because in the next study, patient population is different. That's an important caveat. Patients received fludarabine lymphodepletion and a fixed dose of CAR T cells. Primary endpoint was PFS, and median follow-up was 18 months in this study. Results: 1-year PFS was 55% versus 30% in the control arm. That was significantly better. Median duration of response was also significantly better. Interestingly enough, there were no infection rate was similar between the two arms. Grade 5 adverse effects was also relatively similar, and CRS and neurotoxicity was relatively low. These are patients' characteristics. This is how survival curves look. Significantly improved PFS in the treatment in the CAR T arm. The second study is a very similar study, which randomized cilta-cel this time, or standard of care, in lenalidomide refractory multiple myeloma. So early stage patients, these patients were refractory to 1 to 3 lines of prior therapy. Again, phase 3 open label randomized study, randomized 1 to 1. These were largely DARA naive patients, and only 14.4% had triple class resistant disease, 24% resistant to daratumumab in the cilta-cel group. High-risk cytogenetics, 59% versus 62% for the control arm, and median follow-up was 15.9 months. Median PFS, again, was better. Overall response was significantly better, 84.6% versus 67.3% for standard of care. CR rate was 73% versus 21.8%. A lot more patients, 66% versus 15%, achieved MRD negative CR, and 1-year PFS was 75% versus 48%. And there were low rates of CRS and neurotoxicity. Again, infectious complications were similar between treatment arm and control. And these are survival curves. It appears that cilta-cel in this group does better than the ide-cel in this one. But in fact, if you look at the control arms, obviously controls are also different in the sense that for cilta-cel, control did better because they received less number of therapies. So some believe that cilta-cel is better. I don't think we can really conclude based on these studies, although it is true that progression-free survival curve for cilta-cel appears better. So this brings me to the first abstract, which is a phase 2 CARTITUDE-2 trial, updated efficacy and safety of cilta-captagene autoleucel in patients with multiple myeloma after 1 to 3 lines of prior therapy, cohort A, and in early relapse after first-line treatment with cohort B. And this is, again, phase 2 multi-center study, 2 arms, cilta-cel infusion. So cilta-cel infusion was 0.75 times 10 to the 6 per kg. Primary endpoint was MRD negative CR. Median follow-up for cohort A was 29.9 months. Median follow-up for cohort B was 27 months. High-risk cytogenetics were present in 35% of the patients in cohort A, 16% in cohort B, and 35% in the median line of lines of prior therapy, 35%, 40% were triple refractory, and 85% had prior autologous transplant in cohort A, and only 16% were triple refractory in cohort B. Results were quite impressive, with overall response rate in 95% and 100%. in the two cohorts. Stringent CR was 85 and 73% respectively. CR rate was also VGPR low and CR low, because most patients obviously achieved stringent CR, and duration of response was not reached. Next, I would like to talk about another study recently published in New England Journal of Medicine with GPRC5D target CAR T-cell therapy for multiple myeloma. This is a protein of unclear function in human tissues, but is expressed in plasma cells of multiple myeloma patients. This is a phase 1 dose escalation study. Patients received greater than 3 lines of prior therapy. Most patients received prior BCMA therapy. They received fludarabine lymphodepletion and doses ranging from 25 times 10 to the 6 to 450 times 10 to the 6 cells fixed dose. Primary endpoint was safety and maximum tolerated dose, and this was a 3+3 study design. Median age of the patient was 60, ranging from 30 to 76. Median number of prior therapies was 6. This is I think this was a memorial study. 59% of the patients had prior BCMA therapy. 8% had prior BCMA CAR therapy. 76% of the patients had high-risk cytogenetics. 82% were refractory to last therapy. Interestingly, CRS occurred in 88% of the patients, mostly grade 1, 2, and ICANS occurred in one patient along with the HLH at the highest dose, and there were some new toxicity observed, including 2 patients had significant cerebellar toxicity because of GPRC5D presence in inferior olivary nucleus, and there were significant nail changes in these patients that apparently resolved in most of them. Overall response rate was 71%, with 35% achieving CR or stringent CR, and flow negative CR was achieved in 2/3 of the patients at some point during treatment. And 70% of BCMA treated patients had at least PR, and 6 of 12 patients, approximately half, achieved at least PR, who achieved at least PR last treatment, remained progression-free. This brings me to abstract number 219. This is a BMS study using CAR against GPRC5D protein for patients with relapsed and refractory myeloma. This results from a phase 1 study. Dose escalation. Patient had to have greater than or equal to 3 lines of prior therapies. Prior BCMA treatment was allowed. Escalation dose ranged between 75 to 450 times 10 to the 6 CAR T cells. 70 patients were treated. About half have high-risk cytogenetics. 57 had 1q abnormalities. And the treatment was relatively well tolerated. CRS overall response rate was 86%, CR rate 38%, and patients who received prior BCMA therapy had a good response, overall response 85% and 46% CR rate. And this is the response rate based on doses received and whether or not they receive prior BCMA therapy, and most patients achieve at least a VGPR. Moving on to CAR T-cell therapy for lymphoma, I'll start with this recently published paper which describes long-term 5-year follow-up from ZUMA-1 study, which supports curative potential of axi-cell in refractory large B-cell lymphoma patients. 111 patients were enrolled, 101 were treated. Median age was 58. All patients received fludarabine lymphodepletion, 2 times 10 to the 6 CAR T cells per kg. Overall response rate was 83%, CR rate was 58%, 5-year overall survival was 42%, event-free survival of 30%. Survival curve looked great, and the authors found that early response and expansion of CAR T cells in recipients' blood correlated with response and survival. Next abstract I want to discuss is 1032, 5-year outcomes of patients with large B-cell lymphoma treated as standard of care. This time, this is a retrospective study of a CAR-T consortium. Patients received standard of care axi-cell, 17 centers involved, 275 patients treated. Median follow-up for this group was 58 months. 5-year cumulative incidence of relapse was 55%. 5-year non-relapse mortality 16.2%. And I put outcomes at 3, 4, 5 years in this table. Overall survival at 5 years was 40%. Progression-free survival 28.5%. There is really, I don't believe there's maybe a plateau will emerge after 5 years in this group. In conclusion, this study shows that even in standard of care setting, probably many patients were not eligible for the study. There is still, outcomes are similar with the 5-year PFS and overall survival of 28.5% and 40.3%. Next is Abstract 894, 3-year analysis of results of ZUMA-12 study, a phase 2 study of axi-cell as first-line therapy in patients with high-risk large B-cell lymphoma. And this is obviously patients with high-risk disease treated early. Patients had MYC, BCL2 and or BCL6 rearrangements, double or triple hit histology, or a high IPI plus positive interim PET after first 2 cycles of chemotherapy. Patients received flucil lymphodepletion, the same dose of CAR T cells, and 42 patients were enrolled, 40 were treated. Median follow-up was 40.9 months. 37 patients were evaluable for response. Overall response rate was excellent, 92%. CR rate was 86%. Responses were ongoing in 73% at last follow-up. And 36-month estimates for duration of response, event-free survival, progression-free survival, and overall survival are listed here. There were no new toxicities in addition to what was already reported in the earlier study. And so no other safety concerns, no significant cytopenia or other adverse effect, except one patient had esophageal carcinoma. So a number of patients, a small number of patients, unfortunately develop secondary cancers after CAR-T, as you might already know. These are the event-free survival curves and overall survival, which look spectacular. Abstract 781. This is an interesting retrospective study performed by CIBMTR, looked at transplant outcomes versus CAR T-cell therapy outcomes for patients with large B-cell lymphoma who achieve complete remission after treatment. So this is a cohort of patients age 18 to 75 who achieved, again, remission after treatment. 360 received either CAR-T or went on to receive an autologous stem cell transplant. Median follow-up was 24.7 months. Patients receive either axi-cell or lysocell or TISA-cell. TISA-cell, axi-cell, and lysocell. In multivariate analysis, CAR T-cell therapy was associated with higher risk of relapse and inferior progression-free survival compared to autologous transplants. Overall survival, there was a trend, but this was not significantly different, and there were, interestingly, no difference in 2-year treatment-related mortality, 4.1% versus 5.9% in the CAR-T. These are the survival, progression-free survival curves between autologous transplant patients and CAR-T patients, again, who received treatment in first complete remission. So, in conclusion, patients who relapsed with relapsed large B-cell lymphoma who achieved CR may still benefit from an autologous stem cell transplant due to a lower relapse rate and improved progression-free survival. Moving on to abstract 311, this is another interesting study looking at it's another retrospective study looking at CAR T-cell therapy for older patients with relapsed and refractory large B-cell lymphoma. This is a retrospective multi-center study on 209 patients, all above age 65. Median age was actually 71, ranging to age 89. These are characteristics of these patients are listed here. Median follow-up for this cohort was 19.1 months. Overall response rate at day 30 was 84%, CR rate was 52%. Median PFS at 1 year was 43%. Non-relapse mortality at 1 year was 17%. And interestingly, these patients appear to have a higher risk of significant neurotoxicity, with approximately 29-30% of the patients had greater or equal to grade 3 neurotoxicity. Inferior overall survival was noted in patients with ECOG greater or equal to 2, bulky disease, high LDH, and need for bridging therapy. Interestingly, survival curves were not different for different age groups as listed here. So age by itself did not appear to negatively impact survival. Next abstract is 1025, a novel CCAR039 is a novel anti-CD20, CD19 bispecific CAR T-cell therapy. Results from a Chinese study for patients with relapsed refractory non-Hodgkin's lymphoma, long-term follow-up. Again, the group reported early outcomes at ASCO in 2021. Here, they updated results for 48 patients with median follow-up approximately 2 years. This was an open-label, multi-center study for patients with diffuse large B-cell lymphoma. Patients received 1 to 5 × 10^6 CAR T-cells per kg after 3 days of lymphodepletion chemotherapy. Primary objectives was safety and efficacy, and other secondary objectives are listed there. 48 patients were treated. 44 patients had large B-cell lymphoma. There were a few patients who had follicular lymphoma or mantle cell lymphoma. Interestingly enough, these cells were manufactured in the Miltenyi Biotech Clinimax Prodigy system. Median age for the group was 55 years. The characteristics of these patients are listed here. Overall response rate and CR rate among evaluable patients were 91% and 85%. These patients did not fail a prior CAR. I think were CAR naive, a CD19 CAR. Although newer other studies now will allow patients who failed a CD19 CAR on a dual CAR like this. Of 43 diffuse large B-cell lymphoma patients, 90% and 86% had a response rate in general and CR rate respectively, and 24 months estimation of PFS and overall survival was 66% and 77.9% respectively. This slide shows response rate in these patients in green. Most patients achieve CR, great majority achieve CR in yellow. Next abstract I want to talk about is this 355 predictors of CRS and neurotoxicity in patients with large B-cell lymphoma and their impact on survival. This is another retrospective study. It was performed by CIBMTR on almost 2,000 patients who receive either Yescarta or Kymriah, treated between 2018 and 2020. I'm going to finish with this one, so I think I'm running out of time. So 9% of these patients had severe CRS, 20% had severe ICANS. In multivariate analysis, factors associated with the development of CRS were gender, more common in women, high LDH and product, Axicel is with an odds ratio of 4.6, more likely to be associated with CRS. Factors associated with development of ICANS were age greater than 65, KPS less than 80, disease status not in remission, resistant disease to treatment or untreated relapse, and again, same product, Axicel. Overall CRS, early onset CRS and overall ICANS were not associated with higher mortality. However, development of greater or equal to 3 grade CRS, greater or equal to 3 neurotoxicity, and early onset of ICANS less than 7 days were associated with higher treatment-related mortality. So the authors conclude that first, it is again what was known and suspected for a long time, that Yescarta is a little bit more potent, and it is associated with more toxicities. Higher LDH, older age, lower performance status influence treatment outcomes, and development of severe CRS and ICANS and early development of ICANS neurotoxicity impact negatively outcomes of these patients. And these curves show that patients who did not have CRS or who had CRS less than 3 did better than patients who had severe CRS. I'm gonna end up here. There are a number of other abstracts that you may want to look up, and thank you for your attention. Thank you.